Okay, so my objective today will be talking about some terminologies. Sorry for the misspelling. And then we'll talk about some pulmonary mechanics. We'll talk about loops and the graphics, and we'll end the talking about modes of ventilation. I'm hoping that you guys can understand the process. So again, terminologies and pulmonary mechanics, loops and graphics, and then mode of ventilation. The first terminology that we will talk about is PEEP, or the positive end expiratory pressure. It is the pressure need to maintain the alveoli open, or in other words, it's the pressure between two breaths. Because during the breath, there is inspiratory pressure we weren't able to measure. So it's only being measured between the breaths. The physiological level of the PEEP, or what we call it intrinsic PEEP, is about 3 to 4 centimeters. If you want to improve the lung compliance, you give more than that, and you give about 5 to 6 centimeters of water. And how we measure PEEP? We measure PEEP, as you all know, that atmospheric pressure is about 760 millimeter mercury at the sea level. And to move pressure from point A to point B, you need a pressure difference. And therefore, to move the air from outside the body to the lung, you need to increase that pressure. So PEEP is any pressure, because you need to keep the alveoli open. So PEEP is any pressure above the atmospheric pressure. It's the same of the CPAP, but CPAP is not invasive. And the CPAP is the applied pressure. But the resultant pressure, which is the PEEP, is the pressure need to open the alveoli. And here you can see you have two types of pressure. You can see that the PEEP, where the patient is not breathing, and then the patient starts to breathe, which is the PIP, and then exhalate and return back to the PEEP level. So this color is PEEP, this is the PIP. So the PEEP is the pressure need to maintain the alveoli open, or the pressure between two breaths. Now, the PEEP is very important for functional residual capacity of the lung. So if you want to improve it, then you need to give the appropriate PEEP. To know the appropriate PEEP is when the amount of the volume in the alveoli is adequate to maintain a good contact between the alveolar wall and the capillaries. Because you might reach to a point, you give PEEP, you distend the alveoli, but you are not giving extra contact. So the best PEEP is to provide the best contact between the alveolar wall and the capillaries. And you can see when the pressure is 0, the alveoli is open, but it's very small. When you increase the PEEP to 5, you can see the alveoli get bigger, and the contact surface between the alveoli and the capillary wall is increasing. When you reach 10, it increased more. When you reach 15, you see no much difference between a little bit of improvement between 10 and 15. A little bit increase in the contact surface between the alveolar wall and the capillary. But at the 20, there is no difference between 15 and 20, same. So putting the PEEP more than 15 will have the side effect, but will not give you any improvement in the FRC. And therefore, the highest PEEP should be used is 15. Above that, you'll have side effect. What is the side effect of higher PEEP? is the barotrauma. What is the barotrauma? Is the shearing damage. So if you have an air inside a room and the room has a wall and a window, and you increase the pressure inside the room, the pressure will be increasing at the point will start to look at the weakest point in that wall and break it down. And that's what we call it shearing force or barotrauma. While the voluotrauma is exactly when you have a balloon when you have a balloon and then you inflate it to a point where functional residual capacity, FRC is functional residual capacity. So the voluotrauma is when you increase the alveoli, to a point, it causes distensibility, redundancy. And then when you deflate, it won't go back to its normal position. It's like a new balloon. You inflate it, it will never go back to its original size. That's what we call it voluotrauma. So you can see you are increasing the pressure in the PEEP up to a point. You won't get any improvement in the alveolar diameter. So after that point, increasing the PEEP won't give you any benefit, but will give you the side effect. And it's very important to remember that CPAP is not PEEP. CPAP is any pressure above atmospheric pressure that applied to the patient non-invasively. While PEEP is the pressure needs to keep alveoli distended, or the pressure measured between two breaths. However, putting CPAP can provide you with some PEEP. And you can see that you have the PEEP in here, which is the pressure between the alveoli. Of course, during breathing in, it's still there, but you cannot measure it because there is a pressure add to it, and it will become the total pressure, which is the PIP and the PEEP. And you can see at the beginning, the pressure curve represents the alveoli, while at the end represent the airway pressure. So you can see from here to here is the airway pressure, and then you go to a plateau, which represent the plateau pressure, and the lower part of the pressure of the PIP represent alveolar compliance. This total pressure, we call it airway, peak airway pressure, and this one is the air resistance pressure, and this is the alveolar pressure or the compliance. What is the advantage of PEEP? It increases the FRC, functional residual capacity. By improving the FRC and increasing the contact between the alveolar wall and the capillary, it prevents the shunting. What is shunting? You have artery and you have vein, and in between there is capillary. Artery bring the blood, non-oxygenated pulmonary blood, and then send it to pulmonary vein after oxygenation. If there is no good contact, this will move without gas exchange, causing shunt, intrapulmonary shunt. So having better functional residual capacity will decrease the intrapulmonary shunt, and then more contact between the alveolar wall and the capillary, better oxygenation, better gas exchange. And when you give more compliance, more pressure, you get better compliance. Why? Because during breathing in, the patient will need less effort to increase the pressure to the max. What does that mean? Let's say you are giving PEEP of 5 and PEEP of 6, and the patient needs a pressure of 13. Then from 6 to 13 is 7, while from 5 to 13 is 8, which means the patient needs to breathe 8 to achieve same pressure level. That means he starts to increase work of breathing. So improving compliance, increasing more distension will decrease work of breathing because you need less inspiratory pressure. There are many terms in PEEP. There is what we call it applied PEEP, which is a pressure applied by the machine. And there is the auto PEEP, and there is the total PEEP or the effective PEEP. Now, if you look to this diagram, you see two lines the blue lines and the dotted line. The blue line represents the pressure in the alveoli, and the dotted line represents the pressure in the airway. And you can see that the blue line during exhalation, and then during inhalation, exhalation, inhalation. And you can see they are not meeting together because the pressure in the airway, this is wrong, this is alveolar pressure. So because the pressure in the airway does not go back to the normal. So the next breathing started before this pressure goes here. And that will give you an extra PEEP. So you can see this is the alveolar pressure, this is wrong. And you can see the airway pressure. So you can see the airway pressure is in here. And this is what the PEEP we are applying. But the alveolar pressure does not go back to here. And the next breath starts from here. So instead of, let's say, starting from 5, it starts from 7. So you have 2 extra remaining in, and that way we call it auto PEEP. And therefore, the total PEEP or effective PEEP is the sum of auto PEEP and the applied PEEP. And how you know this is true? When you have a flow chart, and we'll talk about the flow chart, always the chart should go back to 0. Flow always should go back to 0 before starting next breath. And you can see here, before starting, go back to 0 to start next breath started. And that's mean we have an air trapping. And that's mean we'll have an extra PEEP. And always remember, the flow should go back to the normal. If you see the flow charts or flow graph does not go back to normal, then remember that there is the breathing, the second breathing started before finishing of the previous one. And that's why you'll have an extra PEEP not generated by the applied PEEP. The other pressure that we'll talk is PIP, or positive inspiratory pressure, or peak inspiratory pressure. Is the pressure during breaths. And remember, there is two PIP, the set that you provide, that the machine provide, and what's the patient actual. Because what the patient actually getting is an interaction between what you provide and the mechanics of the patient. And remember always, there are 2 breaths, well actually there are 3, but they are spontaneous, and there is mandatory, and there is also the assisted one. So you can see that this is PEEP during expiration, and this is PIP, and it's above the atmospheric pressure. The other parameter is the frequency or the rate. The normal rate in the ventilator starting from newborn to adult is the lowest that you can go in adult is 10, and the max in neonate that you can go is 60. And when we talk about respiratory rate or the frequency, we're talking about both the spontaneous and the mandatory. Remember, mandatory is the machine, spontaneous in the patient. These are very important 2 terms that you need to understand when you're setting ventilator. Mandatory, spontaneous. Remember, you can go up to 80 in newborn, very rarely. And there is something called backup rate. And when we say backup rate, we're talking about the mandatory or the machine delivery. And there's the assisted. Assisted mean started by the patient and then helped by the machine. So there is spontaneous patient only. There is mandatory, totally by the machine. And there is the assisted, which you provide started by the patient and then getting help from the machine. The other terminology is what we call it the length of the breath, or inspiratory time. The inspiratory time will cycle or will determine the breath length or breath size. And the inspiratory time can be time cycled. For example, in premature babies, very small babies, we put it at 0.2, sometimes 0.3. And in term baby, we put it to 0.6, 0.5 to 6, and you can reach not more than that. Even you can reach in much less once you get older and older and you need less respiratory rate. So when we say 0.8 and we put the rate at 60, or 0.2 and we put the rate at 60, then 0.8 is the inspiratory time, 0.2 is the inspiratory time, 0.8 is the expiratory time. When we say 0.3, that means 0.3 is the inspiratory time, 0.7 is the expiratory time, because our rate is 60, 1 cycle per minute. But when you put the rate to 10 in adult, you need much longer inspiratory time. The other way to determine the length of the breath or the inspiratory time is by flow cycle. So when you put flow cycle, then the breath size will be vary depending on the patient response. So it's very important to remember when you put it flow cycle, it's patient derived. And that it can increase work of breathing on the patient. So you have to select which one you use, time cycle or flow cycle, depending on the patient. For example, if you have a sedated, paralyzed patient, you go with time cycle. But if you have an active patient, asthmatic, and you need to minimize the sedation, you go with the flow cycle. And of course, you need to monitor it. So you determine the size of the breath or the inspiratory time, and then you need to determine what is the ratio between inspiration and expiration. How much, let's say if you put your rate at 30, then your respiratory cycle is 2 seconds. And if you put the, let's say, inspiratory time 0.5, then you have 1.5 for the expiration. Then your rate, i.e. rate or ratio, is 1 to 3. So you can see here that the inspiratory time is 1 section and expiratory time is another section. Inspiration, flow, expiration. Remember, this is a flow, positive inspiration, negative is expiration. So you have inspiration, expiration. Inspiration, you can see that the expiration is very long. So you can have 1, 2, 3. So you have ratio of 1 to 3. So it's very important. Remember, there is inspiratory time, there is the rate, and the IE ratio. You need to determine only 2 to get the 3 of them. So if you put the IE ratio and the rate, you will get the inspiratory time. If you get the inspiratory time and the ratio, you will get the respiratory rate. If you get the IE ratio and the rate, IE ratio and the inspiratory time, you get the rate. So you have 3 parameters depend on each other. You said 2, you get the 3 of them. Sometimes you need to inverse the ratio. For example, you have a CO2 accumulation or you have a bronchospasm, you can inverse. And this, that the inspiratory time become longer than expiratory time. Sorry, that is not the, inversing ratio is not during bronchospasm, but if you need to increase your inspiratory time without increasing the rate, you can do inverse ratio. And you can see that the ratio is 1 to 2, while here we are inverting it to 3 to 1. The other parameter or terminology is what we call it mean airway pressure, or pressure in the airways. The term mean airway pressure is not preferred because it looks like mean arterial pressure too. So people using this POW or to indicate the mean airway pressure, which is the average pressure applied during the whole respiratory cycle, during the expiration PEEP, inspiration PIP, and the rate. Because you have a PEEP of 6, PIP of 20 is different if the rate is 20 or the rate is 30. So the mean airway pressure affected by PIP, PEEP, and the rate. It's correlated very well with the mean lung volume for a given mode. and a strategy of minute ventilation. And minute ventilation is the volume in one breath times the respiratory rate. The mean airway pressure of more than 10 to 15 in conventional mechanical ventilation associate with side effect. So always you need to keep your mean airway pressure somewhere between 8 to 12. If you reach more than 15, then you will start seeing side effect. So remember, mean airway pressure, and mean airway pressure is not a set, it's a measured one. It's independent. It's dependent variables on the independent factors that you set. So if you set PIP, PEEP, and rate, you get them out. Of course, patient response will contribute. So compliance and resistance will also contribute to the mean airway pressure. And remember that the mean airway pressure that we're talking here is about conventional mechanical ventilation, not high frequency mechanical ventilation. Because the way of calculating the mean airway pressure in high frequency ventilation is totally different from the conventional mechanical ventilation. Well, Abdullah, I'm sorry, we said we cannot answer technical question during the talk. You should come earlier and ask question. So sorry, not answering any technical question right now. The mean airway pressure, my apology, please do not ask me about any technical question. I was waiting 15 minutes for technical questions. And that will interrupt the talk. So again, the mean airway pressure calculation in conventional mechanical ventilation is totally different from the mean airway pressure calculated during high frequency ventilation. The other parameter is what we call it minute volume, is the amount of the volume in 1 minute. And minute volume including the rate times the tidal volume. For example, if you have 30 breaths per minute and you're giving 66.5 mil per kg, then your rate will be 260 per kg per minute. This one times this one. That's what we call it minute ventilation. And when you have a good mean airway pressure, you will have a good minute ventilation. And now we're talking about tidal volume. So we talked minute ventilation, which is the volume during 1 minute, and tidal volume is the volume during 1 breath. Okay, and when we say minute ventilation is the average during entire respiratory cycle. And we know respiratory cycle, including the airway and the alveoli. So when we talked about tidal volume, we're talking about the change of the volume in the airway and the alveoli. We're not talking about the dead space, because that's not calculated. And it correlates very well with the minute ventilation. And the tidal volume measured in mil, and usually in pediatric we put it over kg. And it's very important to remember that volume depends on the time. So if you want to change the time, the volume, the machine will change the time of the flow, because flow produces both pressure and volume. Flow in time, you get volume. Peak flow, you get pressure. That's very important to remember. Volume is time. Pressure is peak. So volume is the time of the flow, while pressure is the peak of the flow. So to calculate volume, you multiply the flow by times, or you divide minute ventilation by the respiratory rate. The size of the breath will change in volume limited and pressure limited ventilation, and in the volume guarantee, which we will talk about it. When you say volume limited, that means you set the volume and let the pressure change to achieve that volume. When it's pressure limited, you set the pressure and the volume will change to set that pressure. And the volume also affected by the type of the breath, mandatory, machine delivered, or spontaneous, patient delivered. And now we'll talk about what we call it the loops. And loops mean one cycle dynamics, or the relation of different parameters in one cycle. And one of the very important loops is the pressure volume loop. Because remember, when you give a pressure to the alveoli, consider the alveoli like a balloon, the balloon gets distended. So you get pressure, you get distension. And the thinner wall alveoli will get better distension, while thicker wall will get less. And therefore, pressure volume loop will give you an idea about compliance. So here is the volume, and here is the pressure. We don't have time here. We don't have time. It's a one cycle. So the pressure increased, the volume increased. It starts the increment of the volume with increasing pressure is very tiny until you reach the opening point where the volume shoots. And then you reach to a higher pressure, or we call it PIP, peak inspiratory pressure, after which there is no increment on volume. Then the pressure starts to drop, drop, until you're reaching to a closing point where the pressure goes down. And this relation goes again and again. So if this moves to the right, that means you get more pressure to get same volume, then your compliance is decreasing. But if this moves to the left, that means you get less pressure to get same volume, then your compliance is improving. So turning right, turning left, better compliance. Turning right, increase compliance. Turning left mean decreasing pressure to give same volume. Turning right, increasing pressure to give same volume. When you see peaking of this area, that means you are over distending your alveoli. You are giving higher than required PIP, or your PIP is not returning to the original line before starting a new cycle. So you have air trapping, which means that you have start to have an auto PEEP from your either limiting the time for the PIP to go to the baseline, or you're giving higher than required PIP and the time is not required for this high PIP to go to the origin. So either your time of breath is high or your pressure is high, and you start to have air trapping. The other loop is called flow volume loop. And this is different from spirometry, because in spirometry, you will have expiration here and the inspiration down. This is in the ventilator is different. And in ventilator, you have forced inspiration, but you have passive expiration. While in spirometry, you have passive expiration because you're asking the patient to expire out, to exhale. So it's very important to remember that this is a flow has a positive and have a negative deflection. The upper part is the inspiration, the lower part is expiration. The inspiration is forced by the machine, the expiration is passive by the patient, and recoil characteristics of the respiratory system. And you have the flow in this way, and you have the pressure in this way. And this is your tidal volume in here. And this is your peak inspiratory pressure, or a peak inspiratory flow. And this one is your peak expiratory flow. Okay. So again, flow volume loops is very important to differentiate between obstructive and restrictive lung disease. In obstructive lung disease, you get less volume because you're sending less inside. So you have a flattening of the expiratory phase, you have a blunting or scooping of the expiratory phase, and you have reduction of the expiratory flow. And you can see that your flow does not go back to the zero. You can see this area, it does not go back to the zero. So these are three signs of obstruction: blunting of the, or flattening of the inspiration, scooping of the expiration, because there is a reduction in the expiratory flow, and the curve is not returning to the zero. The curve is not returning to the zero. While in restrictive lung disease, you can see you have a good flow, but you don't have volume because your alveoli is not distended. So you can see that there is peaking or steeping end of the inspiratory flow and steeping of the expiratory flow, but you have less volume because restriction means less volume, while obstruction is problem with the expiration phase, and then it will become both of them. And then there will be no time because you need longer time for the PIP to go out, and then that will not return to its original position, and therefore you will have air trapping. The other terminology, we call it time constant, which is a multiplication of compliance versus resistance. I'm not going to talk about it, but usually we need to save it 3 times the normal to get a neutral position. So I'm not going to talk about time constant. And then one we're going to talk about what we call the graphics. And graphics showing us is the rate dynamic, or comparing breath and another breath. Remember that loops comparing one cycle, parameter versus parameter, while graphics comparing one parameter in different rate over time. So it shows us the change of breathing dynamics with time. And it can be flow, can be volume, can be pressure against time. So if we go to the graphics of the pressure, we will have 3 types of the waves. So remember this is PEEP and this is PIP. And when we talk about waves, a pressure wave, we are talking about shapes of the PIP. So we have a pressure, we have time. We have inspiration, we have expiration. This is PEEP during expiration, this is PIP. The total colored area is the map. So you can have the triangular, or what we call it exponential rise. You have the other shape, we call it rectangular, and we have the sinusoidal shape. So you'll have 3 shapes, and each one has characteristic. So for example, if you remember that we said the volume is time. So if you keep the pressure on a certain time, mean you're giving better. So this is a pressure limited ventilation. This is volume limited ventilation. This is a combined one. Now this is not the point to talk about this, but the shape determined what is your ventilation type. The other graphics is the flow waveform graphics, and the flow give us like different type of you give us what we call it descending ramp, where the flow shoot up and go slowly backward, shoot up and go slowly backward. And then we're gonna have the square shape, or what we call it the exponential decay, and you have the sinusoidal, and you have the ascending ramp. So we have 5 shapes of graphics when we look at the flow, and each one has its own characteristic. We'll talk about it in details when we talked about different type of ventilation. And there is what we call it the volume curve. And you remember that the volume is only one side. There is no negative deflection. And you have only 2 types of, this is 5 and 4 is wrong. Unfortunately, it's 1 and 2. But you have the ascending ramp and you have the sinusoidal shape. So the graphics of the volume, you have only 2 shapes. If you combine 3 of them and look at them same time, So you have the pressure graphics, you have the flow graphics, you have the volume graphics. You compare parameters in different respiratory cycle with time. And you can see that there is different shapes. You can see that this is assisted breath. It's a combination between patient and ventilator. You can see this is spontaneous, not assisted, spontaneous, not assisted, asynchronized. So you have the assisted and the patient coming together, but they are asynchronized. So depending on the mode of the ventilation, you will know what is going on. And you can see that the flow of the assisted ventilated breath, the flow of spontaneous, and you have two types of flow. The machine and the patient, they are coming not in a proper time. And you can see also the volume give you an indication what type of breath. And remember, we have three types of breath. You have the spontaneous, you have the mandatory, given by the machine only, and you have the assisted. So these are very important to remember. Again, this is graphics. It shows us the changes with respiratory cycle of the three parameters. Also, the graphics will show us the respiratory cycle. So you can see it will show us the initiation of inspiration. This is a pressure. And you can see the patient is triggering because the patient going down, creating negative pressure, expanding the chest, and then starting the breathing in. So starting in, open the airway pressure goes in, then the pressure becomes positive. Start with negative. When you see this, that's mean a pressure trigger. Very important to remember. So you can see that this is inspiratory initial phase, and you can see inspiratory phase. You can see the alveolar part of the inspiratory phase, and then you can see the expiratory phase. So also graphics will show us the phases of respiratory cycle. It shows the changes between the breath and breath, show us the changes of parameters with time, but also shows the respiratory cycle. So these are, we were talking about the different types of respiratory cycles. We have the mandatory. So you can see mandatory, shape, constant, never change because it's a machine delivered. And you can see the assisted. You can see the patient is creating the negative pressure, and then machine will give negative pressure, machine will give. So this is assisted. And you can see spontaneous of different shape. They're never constant. So graphics will show us also the type breath. So graphics changing between parameters with recurrent breathing also show us the respiratory phases or respiratory cycle, but also show us the changes with time, and also will give us idea the type of the breaths. Also, graphics will show us whether there is synchronization or there is no synchronization. Is the machine delivered breath, the mandatory, synchronized with the spontaneous or not? So you can see here is very synchronized. When the patient breathes, trying to breathe, machine gives the patient a breath. You can see this is spontaneous, not assisted. And you can see this is asynchronized. It's like a crazy, like a machine and then a patient. So the graphics will show us whether the patient synchronizing and not synchronizing, and what we can do if there is no synchronization. Also, the graphics will show us whether the trigger, how we are assisting, if they are assisting the patient to breathe, how we are assisting the patient. Are we? Can you please mute your mic? Thank you very much. So the patient trigger are of different type. It can be triggered by flow. So when there is movement in the flow, the machine will give the help, or change in breath, the machine will help, or neural. There is probe attached to the chest wall and looking to the electrical activity, especially of the diaphragm. And then when there is electrical changes or EEG change or ECG changes, then it will give the breath. So the trigger also can be shown by the graphs. Now this is give you an example how a trigger works. So you can see the patient is breathing in and then breathing out. In and out. There is no change between in and out. That means the patient is not breathing. So this is connected to the patient. This is the airway of the patient. There is in amount of volume or flow going in, same of out. That means patient not doing any effort. Now there is in, patient start to get some, there is an effort, then in will not equal out, and the machine will trigger the breath. So this can be flow, it can be also pressure. And here an example of trigger. So patient is breathing in, machine will trigger. Patient didn't do any effort, machine give him his trigger. Patient making effort, machine give the trigger. So this is assisted, this is mandatory. Assisted, mandatory. You can see that the patient start to get some flow and the machine will give. No effort of the patient in a period of time, the machine will give the mandatory. And here is again the trigger by the flow. So when you see this kind of curve at the beginning of the flow, you know that this is flow trigger. Also, there is in the ventilator, there is variables that control the ventilation. These variables, pressure, volume, and flow. Each of them is expressed as a function of time. And the variables are conditional and non-conditional. What does that mean? If you set PEEP, the patient will get. But no, I would say trigger of 0.2 liter or 0.2 ml. So if the patient does 0.2, give him the help. That's a conditional. If the patient is not making effort less than 0.2, then don't help. So there is conditional variable, there is and there is also phase variables, how to start, how to sustain, and how to end a respiratory cycle. Now, the pulmonary mechanics is we're talking about compliance and resistance. Remember, resistance is airway. Compliance is alveoli. Compliance is the pressure and volume. Resistance is pressure and flow. And remember, as we talked, volume is flow in a time, while pressure is the peak of the flow. It's very important to remember to understand ventilation. So we have a compliance. I won't go to the normal and abnormal, but in compliance means distensibility of the, and increasing compliance, decreasing compliance can give you volumetrauma, while resistance is the airway. Now we'll talk about mode of ventilations. The modes of the ventilation, the mode determined by the characteristic of the set parameters that we talked about. And also, when we set our parameter and selected a mode, we expecting some measured parameter. And the modes can be volume limited and can be pressure limited. Volume limited is that you fix the volume. So it's independent. And the other parameters that resulted from interaction of the patient and the machine will be the dependent, because it depends on both. If you are pressure limited, you fix the pressure and leave other parameters. Now, the volume limited ventilation, the clinician set the peak flow rate. The peak flow rate will give you the inspiratory time and the ratio. We'll also set the flow, tidal volume, respiratory rate, PEEP, and FiO2, while the map will be variable. The PEEP and the map will be variable because you are volume limited. Again, inspiratory time, IE ratio determined by the peak inspiratory flow rate. increasing peak inspiratory flow rate will decrease inspiratory time because you need like fast time to go, increasing your expiratory time and decreasing your IE ratio. In volume limited, the patient variables is the compliance and the airway resistance. Why you get high airway resistance? Either you are giving large charge of volume, so you're giving, because remember, volume is the time of the flow. So you need giving longer period of time to, and you get more resistance, or you are increasing your peak flow, or you have poor compliance, or you have increased airway resistance. That's all will give you high airway pressure. A pressure limited ventilation, the clinician said the PIP, the IE ratio, the respiratory rate, the PEEP, and the FI2. Remember, when we talked about PEEP, we were talking about applied PEEP. And the inspiration and after delivery of the set test. The tidal volume will be variable. The tidal volume depending on these variables and the patient response. So the tidal volume in the pressure limited depend on the PIP, on the compliance, on the resistance, and in the airways and in the machine. And it will increase the tidal volume when the PIP is high, when you have a good compliance, we have no resistance in the airway and no resistance in the machine. Again, we talked about it, the pressure is constant because it's a pressure limited. So we said the PIP, we said the applied PEEP. So for example, this is an example, I don't want to go to details. But in short, that you said the PIP and the PEEP, all the pressure related, and you get the variable volume. In pressure limited, the PIP and the rate give you the minute ventilation. While in volume limited, the rate and the volume give you the minute ventilation. So again, pressure limited, you're setting the pressure, keeping the volume variables. In volume limited, you're fixing the volume, keeping the pressure variable. So I don't want to go there, I want to start them. Now, these are different modes of ventilation. This is CPAP, because you won't able to give a PEEP only in an intubated patient, and that's why we've said here CPAP. So this is distension pressure. The rest of the action is by the patient. Machine is not providing anything. PSV, everything is provided by the patient. You are just giving pressure support, what we call it pressure support ventilation. So you're not doing anything, just giving pressure. You're giving PEEP and you're giving PIP. And the rest is by the patient. The TI, the volume, the duration, it's all patient derived. So most of the action of the PSV is by patient, little by the machine. In IMV, or intermittent mandatory ventilation, so there is no assisted and there is no spontaneous. There is no assisted, very important to remember. There is no assisted, there is none. It's only, machine is only giving the help of mandatory. So any spontaneous will be by the patient. So the patient still doing the most of the work in IMV and the machine giving any help. When it's become synchronized IMV or synchronized intermittent mandatory ventilation, the machine will help more because it synchronizes with the patient. This is wrong. So the next will be assisted control. Assisted control, from its term, it provides a control rate by the machine and it assists the patient. So CPAP, PSV, IMV, SIMV, assisted control. Assisted control, the SIMV is providing mandatory breath only. The spontaneous is provided by the patient. There is no assisted, but the mandatory is synchronized with the patient trying to breathe. Assisted control, it provides the control, the mandatory, and also help the patient, assist the patient. That's what we call it, assisted control. Airway pressure release ventilation, it's exactly like control mandatory ventilation, exactly same, but the difference here, in a simple way, the PIP become PEEP and the PEEP become PIP. So the PEEP become very long, the PIP, and the PEEP become short. It's the reversing of the respiratory cycle. But conventional or mandatory ventilation, you can see it's only mandatory. There is no spontaneous. So this area is the patient contribution. This area is, so if you have a tired patient, you have a paralyzed patient, you have a comatose patient, you go with CMV. Or you go with assisted control. While if you have a patient who is awake and driving, not premature, you can go with PSV. Again, you can see that this is controlled mandatory ventilation. It can be volume limited. It can be pressure limited. The patient, the ventilator trigger, yes. In pressure limited, the ventilator trigger. Conventional mandatory ventilation or controlled mandatory ventilation. Is the patient providing anything? The answer is no. How to do, how to cycle in volume limited? Using volume. How to cycle in pressure limited? Using time. What type of the breath you see in the graphics? You see mandatory, you don't see assisted, you don't see spontaneous. You see mandatory, you don't see assisted, you don't see spontaneous. This is controlled mandatory ventilation. It's a ventilator that everything done by the machine. Patient is not contributing anything. And then come the assisted control. Assisted control can be volume limited, can be pressure limited. Is the ventilator trigger? Yes. Is the ventilator trigger in pressure limited? Yes. Is the patient trigger too? Yes. So you will have the mandatory and you'll have the assisted. Will you have spontaneous? No, because every breath tried by the way will be held by the machine. So in assisted control, if the second, the patient has some help, but it's also mostly by the machine. So you will see that the ventilator trigger and the patient trigger, how you volume limited by volume, how you pressure limited by time. Do you see mandatory? Yes. Do you see assisted? Yes. Do you see spontaneous? No, because the machine will not allow the patient to do any spontaneous, will help all the breath. Now the intermittent mandatory ventilation, it can be synchronized, it can be asynchronized. So it can be SIMV, it can be IMV. Are they of two types? Yes, it can be volume limited, it can be pressure limited. Is the ventilator triggered? The answer is yes. Is the patient triggered? The answer is yes. How to control both of them? Using time. What are the type of the breath you see in intermittent mandatory ventilation or synchronized intermittent? You see mandatory, you see assisted. If the patient achieve certain level of trigger, it will be help, but also you see spontaneous, where the patient does not achieve a certain set parameters to allow the machine to help. So you can see that in SIMV or IMV, a patient are doing something good. So if you want to prolong breathing patient and you don't want to lose the function of the patient respiratory system, you go with this SIMV. But if you feel that the patient will get tired, then you need to take control. You use assisted control. But when you want the patient to take some part of it, you go with SIMV. But remember, because the patient is driving to the machine, they will get tired and exhausted with time. What is pressure support ventilation? It's only pressure limited. Does the machine trigger? No. Machine will only provide the pressure. The patient trigger? Yes. How we cycle? We can use the flow, pressure, and time. Do you see mandatory? The answer is no. Do you see spontaneous? The answer is no. Do you see assisted? Yes, because all the breath will be assisted. So the patient do everything because he not get mandatory. There is no, unless you put a backup rate. Even in PSV, you have backup rate. So it become combined type of ventilation. What about CPAP? Nothing. You just are giving a flow. Because remember, the peak of the flow is the pressure. The time of the flow is the volume. Is there a spontaneous? In CPAP, yes. Is there mandatory? The answer is no. Is there assisted? Answer is no. And tube compensation, I will not talk about it today. Now we'll talk about each mode alone. So we have controlled mandatory ventilation. The minute ventilation in controlled mandatory ventilation determined by the tidal volume and the respiratory rate. The patient will provide nothing. The minute ventilation is provided by the machine. So whatever you set, the patient will get. So in controlled mandatory ventilation, it's all mandatory. There is no assisted, there is no spontaneous. Where you use controlled mandatory ventilation, if you're giving muscle paralysis, if you are heavy sedated, or if you have coma, or if you have fear that the patient will get exhausted with time. The problem with the controlled mandatory ventilation is the patient is lacking the incentive to work. Because when the set parameters meet or exceed physiological need, patient won't do nothing of that. So he might overventilate without you noting. That's one of the side effects. Again, controlled mandatory ventilation required nothing from the patient. This is an example of graphs of controlled mandatory ventilation. You can see mandatory, mandatory, no assisted, no spontaneous. Very clear. And you can see it's a flow limit. When you see flow limit, when you see the flow is not blunted, that's mean it's a pressure control. Because again, remember, when the flow reach the peak and stop, this is pressure control. When the flow remain constant, that means it's a volume control. Because CMV can be pressure volume. So when you see its angle, it's a pressure. When you see the flow like a triangle, the angle, then this is a volume limited ventilation, a pressure limited ventilation. When you see it like a square, then it's a volume limited ventilation. And here you can see it's a volume limited. See, here you can see it, sorry, this is the flow limit, and you can see pressure limited, and you can see that it's also volume controlled. Now we'll go to assisted control. In assisted control, clinician determine the minimal MV, not the whole MV, as in here. Here, remember, in controlled mandatory ventilation, the clinician set the whole, patient does nothing. While in assisted control, the clinician set the minimal minute ventilation by setting appropriate respiratory rate and tidal volume. but the patient can help. When the patient help and trigger extra, the machine will give it. So you, in assisted control, you will see the mandatory and you'll see the assisted, but you will never see a spontaneous. So the machine will not exhaust the patient. So you will see the mandatory, and also you see that when the patient initiates breath, he received the tidal volume. So the patient will have minimal tidal volume set by the clinician, and whatever extra effort he's doing will be helped too. An example, if the clinician set the rate of 40 and tidal volume of 4 per kg, and the patient's 2 kilo, then it's 8. Then the lowest possible is 320 mil, which is multiplication of 40 times. If the patient have extra 5 breath over the preset, is not 20, it's 40. The ventilator will deliver 8 mil for each additional breath, and the patient will get extra 25 mil, extra 25 mil. And here's the graph of assisted control. All breaths are supported. Preset rate will be delivered, and there will be extra if the patient. So if you set inspiratory time, or the ratio, inspiratory time and the ratio to give these mandatory breath, and the patient breath in between, you get extra help. And you can see the flow is the same shape, and you can see that the flow is tapered. So it's a pressure controlled, and it's not volume controlled. You can see the volume is of different size. So again, assisted control, clinicians set the minimum, and anything extra above it patient can trigger, it will also help. And therefore you'll see the mandatory and you'll see the supported. And you can see the supported, you can see here's the line, the trigger. Now the IMV, intermittent mandatory ventilation. It's similar to the assisted control in 2 ways. Clinician also determined the minimal minute ventilation by setting the respiratory rate and tidal volume, but patients are able to increase the minute ventilation. However, intermittent mandatory ventilation differs from assisted control, that there will be a spontaneous breath. So the intermittent mandatory ventilation, you will have mandatory and you will have spontaneous. You will never have assisted. That's the difference. In assisted control, you will have mandatory and assisted. In IMV, intermittent mandatory ventilation, you will have the mandatory and the spontaneous, not assisted. If you put S with it, the machine will synchronize the mandatory with the spontaneous. They don't conflict each other. While in IMV, they conflict. And therefore, when you start IMV, you need to make sure that the patient is not breathing. So if you paralyze patient and you give IMV, you are exactly giving CMV. So the patient can increase the minute ventilation by spontaneous breathing, but it will never be assisted. And this is the graphs of the IMV. You can see that mandatory, you can see spontaneous, you can see mandatory and spontaneous not synchronized. You can see that it is pressure controlled, but at the same time, it's a volume control. We'll talk about it. The SIMV is synchronized intermittent mandatory ventilation. It's exactly same of intermittent ventilation, but the spontaneous and then they will never conflict. They always synchronize each other. So the patient will never work against the machine. Here's a graph of the SIMV. So you can see that the machine synchronizes. If you remember the other graph, in IMV, there is no synchronization. Patient breath again is a machine. While in SIMV, you can see that there is mandatory, there is spontaneous, that wasn't help. There is also spontaneous, and the mandatory came together, but they didn't conflict each other. You can see that this is the mandatory, same type, same volume, and you can see the spontaneous, despite the patient was breathing in here. And this is how the SIMV start first breath below volume, second breath above volume until it reach the target volume. And you can see the flow. This is the pressure. It's a flow limited or pressure limited, volume targeted. So you can see that the flow didn't reach, then the flow exceed until it goes down. What is the difference between SIMV and assisted control? These are the most frequently used volume limited mechanical ventilation. SIMV, better patient ventilator synchrony, better preservation of respiratory muscle function, lower mean airway pressure, greater control over the level of support. Auto PEEP is less likely. And the reason, because in SIMV, remember, there is mandatory and there is spontaneous, there is no assisted. While in assisted control, there is assisted and there is mandatory. And therefore, patient is not necessary to do anything. So when you have very sick patient, you go assisted control. When you have less sick patient, you go with SIMV. So as assisted control is suited for critically ill, and it's better for prematurity also. And it's better for sick patient. So most of the NICU, they use assisted control. There is what we call it volume controlled ventilation, or also called volume guarantee. And this mode of ventilation is an adjunct. So you use assisted control, pressure limited with volume control. Assisted control, volume limited with volume control. Assisted control, AC, of pressure limited with volume guarantee or volume control, or what we call, people call it ACVG. And remember, when you see it's a volume limited or it's a pressure limited with volume guarantee, you will see the flow is planted. You will see the flow, because remember, volume is the time of the flow. So flow against time, it will be stopped. As far as it's stopping, not moving down, that means it's giving the appropriate volume. And you can see that the pressure is changing. So it's a volume guarantee. It's an adjunct mode. You add it, it's an adjunct fever. So you have SIMV plus VG. You have assisted control plus VG. Most of the pediatric, we use pressure limited. We don't use volume limited. We use volume limited for short ventilation, like anesthesia or surgery. Well, long ventilation, you use pressure. Because you're using pressure limited, then you will have the side effect of volutrauma. And therefore, we add to it, so it will be pressure limited, volume control. We add to it VG. The one that we are talking about, what we call it airway pressure release ventilation, it's exactly like the SIMV. However, you can see that the PIP represent the PEEP here, while the PEEP represent the PIP. So most the pressure during PIP is long, while PEEP is very short. So it's reverse. So you get pressure, 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 high PIP, and then you release it. You get pressure, 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 and then you release it. And therefore you will have, uh, um, if you have pressure high and you have a pressure low, pressure high and pressure low, pressure high and pressure low, and you will have time high and time low. You will not have PEEP and PIP. And then you will have the time of the high and the time of the short. And usually people set the pressure high and pressure low, 20 to 30, and the pressure low 4 to 6, and the time of the high is it range from 0.2 to 0.3 of the pressure low, and the pressure high can range from 3 to 4 minutes. So again, the airway pressure release ventilation, it's exactly same like SIMV. So it's only mandatory. There is no spontaneous, but it's synchronized with patient breathing. However, you reverse everything. So the PIP become PEEP, or we call it pressure high, and the PEEP become PIP, or we call it pressure low. And it's only used in adult or adolescent. The other ventilation that we talked about, other mode, is what we call it PSV, pressure support ventilation. In this mode, it's only pressure limited. There is no volume limited. And the patient is in control of everything. So there is no mandatory, there is no assisted. It's only spontaneous. However, you're giving him pressure. That's only what you give. You will PEEP and PIP, but the patient control TI, patient control the number of breaths, patient control the IE ratio, patient control the volume, patient control the trigger, everything. So if you use PSV plus VG, that will be the least aggressive ventilation, or what people call it physiological ventilation, because you are giving pressure support and the patient is controlling everything in the minute ventilation, but also you are preventing the side effect of the volume by giving VG or volume guarantee. Volume guarantee means the patient will never exceed that level. So if you say the VG of, let's say, 4 ml per kg, the patient will never exceed 4 ml in any respiratory cycle. But he will control the PIP, the PEEP, because you're only helping it. TI, but it must be below that VG. It will never go above that VG. And because the patient is controlling everything, so and because the patient is controlling everything, it will be exhausting. It will be exhausted with time, and therefore you need to make sure that the patient is okay. And how I give example: you have a driver, you have a drunk driver, and you have a normal driver. If the driver is normal, use PSV plus VG. But if your driver is drunk, then you cannot let him leave the ventilator. Who is drunk? The premature baby, the sick patient, paralyzed. You cannot put driving the car and he's under distraction or under drunk and cannot lead. The other part that we use PSV, we use prior ventilation, because prior extubation, because the patient is driving everything. So when you put the patient on PSV and give him like a 30 minutes, if he's breathing because he's controlling the machine, then you can extubate. Okay, and always with the PSV or any type of ventilation, there is a backup rate. Because when you make the patient leading the ventilation, let's say patient pauses and stop breathing, then he will die because he's leading everything. That's why you put a backup rate. When you put the backup rate, it can be assisted control backup rate, it can be SIMV, you can select. So you would say you breathe anything, you do anything, but don't go below 10. If you're breathing below 10 respiratory rate per minute, which means every 6 seconds, if you're not taking a breath and doing anything, I'm going to give you assisted control, or I'm going to give you SIMV. So always with PSV trial, you use the backup lower respiratory rate. And this is the pressure control. So you can see the flow is peaking up and going back, peaking up, then it's a flow limit, then it's a pressure control. While if you see it's a square sign in the flow, then it's a volume limited. So you can see it's a pressure limited, and you can see the pressure is planted. And you can see there is various tidal volume. And you can see the patient, when patient reach to a flow cycle, start the new phase of respiratory cycle. Again, it's a kind of repetition. It's very complicated slide, but it's a repetition of what we've said. So conventional mechanical ventilation, you set the PIP, you set the PEEP, you set the rate, you set the IT, you set the mandatory. You are not allowing, this said allowed, but you are not allowing spontaneous breathing. There is no backup rate. You set the time. You are not setting the tidal volume if it's a volume controlled. So it's a kind of repetition of what I said. What exactly you do with each ventilation. Sorry, sometimes I pauses because people are coming and going and coming in. And sometimes you use a combination. So you use ICVG, and remember, we always use pressure limited ventilation in long ventilation, unless you're using temporary ventilation, sometimes you use volume control. So you combined assisted control with volume guarantee. So you get helping the patient, control, giving the mandatory, no spontaneous breath, but you're sure they are not, you don't have volumetrauma. Or you can use SIMV plus VG or PSV plus VG. But sometimes also you can use PSV with backup rate. So PSV plus AC or PSV plus SIMV. And even sometimes you can combine high frequency with conventional. It's not our talk high frequency, but you can put high frequency, we'll say a backup rate of conventional. I know it's tough. I know it's not difficult.